Hello, welcome to Pathagonia. This is Jay Huang. Today we are going to cover adrenal and paraganglia tumors. Before we begin, if you already haven't, I encourage you to check out Kurt's Notes website. It has his famous Kurt's Notes, as well as other resources including diagnosis comments and template signouts, quizzes, about me, links, articles, and books. And recently, there's been an article explaining the impact Kurt's Notes has had on surgical pathologists, and I encourage you to look at that article if you have time. Without further ado, let's talk about adrenal and paraganglia tumors. Adrenocortical tumors, on any immunohistochemistry, it'll be positive for SF1, inhibin, melon A, calretinin, and synaptophysin. It will be negative for chromogranin, cytokeratin, S100. On the caveat that it's often variable. Adrenocortical adenoma. This is benign. It's very common, often incidentally identified. It's usually unilateral solitary mass with atrophic background adrenal gland. The tumor cells histologically can be lipid-rich, which looks clearer, or lipid poor, which looks pinker. And it's arranged architecturally in nests and cords, as you can see here, separated by abundant vasculature. You can have occasional lipofuscin pigment, and cytologically, the nuclei generally are small and round. And it's important to note, from time to time, you can see occasional extreme endocrine atypia. You'll have low to no mitotic activity, and you'll have an intact reticulin framework. It's on a spectrum with and may be hard to differentiate from hyperplastic nodules, more often multinodular with background hyperplasia and bilateral. Adrenocortical adenoma is associated with MEN1, FAP, Carney complex, among other syndromes. And if you have an aldosterone secreting adenoma and the patient is treated with spironolactone, you can develop these spironolactone bodies, these pink concentric circular concretions. Adrenocortical adenomas mostly are non-functional, around 85%, or functional, around 15%. If it's aldosterone producing, it'll produce clinical symptoms known as Conn syndrome that includes hypertension and hypokalemia. If it's cortisol producing, it's ACTH independent and known as Cushing syndrome. You'll have central obesity, moon face, hirsutism, poor healing, and striae on the skin. Sex hormone producing, it's pretty rare and actually more common in carcinomas, and the symptoms depend on the hormone and sex of the patient. You can have virilization or feminization. Adrenocortical carcinoma, it is malignant. It's most common in older adults and can present with an incidental unilateral mass or with an endocrinopathy like sex hormone producing. Architecturally, you'll have solid, broad trabeculae or large nested growth. And it's more diffuse and larger groups than in adenomas. You'll have a thick fibrous capsule with occasional fibrous bands. You'll see frequent tumor necrosis and frequent vascular or capsular invasion, as well as increased mitotic activity. They have variants including oncocytic, myxoid, and sarcomatoid. It's mostly sporadic, but it can be associated with Lynch syndrome and Li-Fraumeni syndrome. Here you can see the frequent tumor necrosis. Distinguishing between an adrenocortical adenoma versus carcinoma. We can use the Weiss criteria. It's the most widely used system, but doesn't work as well in borderline cases or variants. The presence of greater than or equal to 3 of these criteria correlates with malignant behavior, and it cannot be used on oncocytic adrenocortical neoplasms or pediatric adrenal tumors, which have separate specific grading schemes. And features only seen in metastasizing tumors are greater than or equal to 6 mitoses per 50 high power field, atypical mitoses, invasion of venous structures. The original Weiss criteria, where you need greater than or equal to 3 features to be malignant, include high nuclear grade based on the Furman criteria, mitotic rate of greater than 5 mites per 50 high power field, atypical mitotic figures, less than 25% clear cells, diffuse architecture, tumor necrosis, venous invasion, sinusoidal invasion, and capsular invasion. There is the modified Weiss criteria, which is designed to be more reproducible. The total score of 3 or greater correlates with subsequent malignant behavior. And the modified Weiss criteria, where the mitotic rate is greater than or equal to 6 mites per 50 high power fields, is 2 points. Cytoplasm characteristics clear versus compact, where compact, if it's greater than 75% of the cells, is 2 points. Abnormal mitoses is 1 point. Tumor necrosis is 1 point. And invasion of capsule is 1 point. And greater than or equal to 3 correlates with malignant behavior. Reticulin algorithm, we look to see if the reticulin framework is intact. If it's intact throughout, it's an adenoma. If disrupted, then you want to move to step 2. Step 2 being malignancy is defined by at least one of the following: tumor necrosis, high mitotic rate, greater than 5 per 50 high power field, and venous invasion. And here we can see this reticulin staining, and it shows intact framework in this adrenal adenoma, whereas in this carcinoma, you have a disrupted reticulin framework. Although this distinction is often straightforward, some borderline cases are likely best categorized as having uncertain malignant potential. And although it doesn't fit into the above systems of the Weiss criteria or the modified Weiss criteria or the reticulin algorithm, Key 67 can also be helpful with this distinction. The proliferation index in adenomas are generally less than 5%, whereas carcinomas have a proliferation index greater than 5%. Oncocytic adrenocortical neoplasms. These are cells with abundant granular eosinophilic cytoplasm, and many require greater than 90% of the tumor cells to be oncocytic. It's mostly non-functional. Often, cytologically, you'll see areas of nuclear pleomorphism, as you can see here, intranuclear pseudo-inclusions or INCIs, and prominent nucleoli. You cannot use the Weiss criteria. Instead, you use the Lin-Weiss-Bisquiglia criteria. And this Lin-Weiss-Bisquiglia criteria is used for oncocytic adrenal neoplasms, where if you have one major criteria, it's malignant and carcinoma. If you have 1 to 4 minor criteria, it's uncertain malignant potential. And if you have no minor or major criteria, it's benign and correlates with an adenoma. The 3 major criteria include mitotic rate greater than 5 per 50 high power field, atypical mitotic figures, and venous invasion. The 4 minor criteria include size greater than 10 centimeters and or weight greater than 200 grams, tumor necrosis, sinusoidal invasion, and capsular invasion. Myelolipoma. This is benign. Histologically, it's composed of mature fat and bone marrow elements. It's the second most common adrenal neoplasm. It's often in older adults presenting with incidental asymptomatic mass, and it can often diagnose on imaging due to fat content. It's rare outside of adrenal, although you can see it occasionally in the pre-sacral region. Ectopic adrenal tissue, where you'll have frequent ectopic rests, sometimes fused embedded with other organs. Don't mistake for invasion or metastasis. Common locations include kidney, where you'll have adrenal-renal fusion/adhesion, spermatic cord, fallopian tube, liver, where you'll have hepatoadrenal fusion. Other entities include schwannoma, which is a benign nerve sheath tumor. You'll have spindled cells with cellular Antony A and hypocellular Antony B areas. Frequently, you'll see Verrucate bodies, lymphoid aggregates, hyalinized vessels, and it'll stain positive for S100 and SOX10. Adenomatoid tumor, this is a benign mesothelial tumor as frequently seen with GYN and GU tracts. You'll see variably sized tubules in fibromuscular stroma, and it expresses mesothelial markers D240, WT1, calretinin. Sex cord stromal tumors. There are rare reports of primary granulosa cell tumors and Leydig cell tumors, all in postmenopausal women. Adrenal medulla and extraadrenal paraganglia tumors. Pheochromocytoma. These are tumors of chromaffin cells that arise in the adrenal medulla. All malignant, but only 10% metastasize. It can occur at any age, but usually older adults, and approximately half are incidentally identified and are asymptomatic. It can make catecholamines, which leads to the clinical symptoms of hypertension, sustained or paroxysmal symptoms, headache, tachycardia, palpitations, sweating, and you can detect with urine or serum metanephrine testing. Architecturally, you'll have classically this nested or Zellballen architecture, and it can have trabecular or diffuse growth, that being said. Cytologically, you'll have polygonal tumor cells with amphiphilic to purple cytoplasm with variable small to large nuclei. There is rich vascularity, often with hemorrhage and hemosiderin. You'll see frequent intranuclear pseudoinclusions and intracytoplasmic hyaline globules that are PASD positive. Nuclear pleomorphism can be prominent, but mitoses are rare. IHC-wise, it'll stain positive diffusely for chromogranin, and synaptophysin. The sustentacular cells will be positive for S100 and SOX10, as you can see here. It will be negative for cytokeratins, SF1, inhibin, melon A, and calretinin. There is no current standardized system to assess tumor risk, and at least 30% are familial due to germline mutations. The most strongly hereditary human tumor is pheochromocytoma. Genetic testing is thus recommended for all patients. Common mutations include SDH, RET, NF1, and if it has an SDHB mutation, there's higher risk of metastasis. Complete resection is the only cure, and you can have metastasis years later. Paragangliomas. This arises from extraadrenal paraganglia, but morphologically and functionally like pheochromocytomas, also frequently hereditary. Personally, I have had confusion with paragangliomas and pheochromocytomas. The way I like to think of it, pheochromocytomas as adrenal paragangliomas. Head and neck paragangliomas. This arises from parasympathetic nerves. The most common sites are carotid body and jugulotympanicum. Generally non-functional, generally good prognosis, less than 5% risk of metastasis. Sympathetic paragangliomas. These arise from prevertebral and paravertebral sympathetic chains and sympathetic nerves, mainly in the abdomen. It's frequently functional, and the risk is similar to pheochromocytomas, and SDHB is associated with higher risk of metastasis. Neuroblastic tumors. These are a spectrum where the most immature tumor is neuroblastoma, in the middle is ganglioneuroblastoma, and the most mature is ganglioneuroma. Neuroblastoma is the most primitive and aggressive. It is malignant. It's a small, round blue cell tumor, and plus or minus you can see histologically rosettes, neurofibrillary matrix, and no Schwannian stroma. Ganglioneuroblastoma is an intermediate differentiation. It is malignant, and you'll have neuroblastoma with Schwannian stroma, and it includes ganglion cells, as you can see here with this Schwannian stroma. Ganglioneuroma, this is the most mature, it's benign. You'll have ganglion cells set in abundant fibrillary Schwannian stroma, and there will be no neuroblastoma nor neuropil. These derive from the neurocrest cells, and the sites reflect the path of migration, and most commonly an adrenal gland, followed by abdominal ganglia, thoracic ganglia, and pelvic ganglia. Neuroblastoma is the third most common pediatric tumor after leukemia and brain tumors. It's the most common neoplasm in the first year of life, where approximately 90% are before age 5. Neuroblastomas will stain for synaptophysin, chromogranin, PGP 9.5, CD56, NB84, FOX2B. Ganglioneuroma, the Schwann cells will be S100 positive. The ganglion cells will be synaptophysin and neurofilament positive. Favorable versus unfavorable histology is determined by the age, degree of neuroblast differentiation, nodular pattern, the degree of Schwannian stromal development, and mitosis karyorrhexis index, or the MKI. Genetics. MYC-N is a major oncogenic driver. Amplification means higher risk. Tumors with whole chromosome copy number gains without structural abnormalities like hyperdiploidy have an excellent prognosis. Composite pheochromocytoma paraganglioma. This is a pheochromocytoma or paraganglioma combined with a developmentally related neurogenic tumor such as a ganglioneuroma, ganglioneuroblastoma, neuroblastoma, or peripheral nerve sheath tumor. Each component stains like it would usually, and it can occur in the setting of neurofibromatosis 1. If surgically resected, usually good prognosis. Here we have the elements of your pheochromocytoma with a Zellbellen architecture, abundant vasculature, and then you have your ganglioneuroma here with your Schwannian stroma. Related tumor syndromes. MEN or multiple endocrine neoplasia 1 and 2. MEN1 is due to the MEN1 gene. It's autosomal dominant. The most common conditions include parathyroid hyperplasia, pituitary adenoma, pancreatic duodenal neuroendocrine tumors. Think 3 Ps. MEN2A is due to your RET gene, and it's autosomal dominant. And the most common conditions are medullary thyroid carcinoma, parathyroid hyperplasia, pheochromocytoma. Think 2 Ps and 1 M. MEN2B, RET, is due to the RET gene, it's autosomal dominant. Most common conditions are medullary thyroid carcinoma, mucosal neuromas, marfanoid features, and pheochromocytomas. Think 1P, 3 M's. And then familial Paraganglioma-Pheochromocytoma syndromes. These are caused by mutations in genes encoding subunits of succinate dehydrogenase, SDH. It's autosomal dominant. You can see mutations in SDHA, SDHB, which is the most common, SDHC, SDHD, or SDHAF2. The most common tumor is a paraganglioma/pheochromocytoma. It can be multifocal. Tumors associated with SDHB mutations are often more aggressive and present younger. Other specific tumors include SDH-deficient gastrointestinal stromal tumors, or GIST. These usually occur in kids or young adults. You'll have epithelioid morphology and can be multifocal or plexiform. They metastasize to lymph nodes, don't respond to RTK inhibitor therapy because they don't have KIT mutations, but overall more indolent. SDH-deficient renal cell carcinoma. Cytologically, they'll be eosinophilic cytoplasm with flocculent cytoplasm/inclusions. You'll have neuroendocrine-like nuclei, where it'll be round, evenly dispersed chromatin, solid to nested architecture. It occurs at a young age and good prognosis. IHC, the immunoreactivity for SDHB is lost in SDH tumors caused by mutations in any of the subunits, and thus can be used to screen for SDH mutations in paragangliomas, pheochromocytomas, and unusual GISTs and RCCs. For instance, if you do a SDHB IHC and it's lost, that doesn't necessarily mean that the mutation is SDHB, because the mutation can also be in SDHA, SDHC, SDHD. Carney triad. This is generally non-hereditary SDHC promoter hypermethylation, and it's going to lead to paraganglioma, SDH-deficient GIST, and pulmonary chondroma. Carney-Stratakis syndrome, you have paraganglioma and SDH-deficient GIST. Well, thank you so much for listening in and our rapid review of adrenal paraganglioma tumors. Adrenocortical tumors, positive for SF1 inhibin melon A, calretinin, synaptophysin, negative for chromogranin, cytokeratin, S100. Adrenocortical adenoma, it's benign, it's common, incidentally found, it's usually unilateral solitary mass. It's arranged in nests and cords. The nuclei are generally small and round, or there's low to no mitotic activity. If it's aldosterone producing, think Conn syndrome. Cortisol producing, Cushing syndrome. Sex hormone producing, it's rare. It's more common in carcinomas. Adrenocortical carcinomas are malignant. Architecturally, you'll see solid, broad trabeculae or large nested growth. There will be a thick fibrous capsule, frequent tumor necrosis, frequent vascular or capsular invasion, increased mitotic activity. Distinguishing between an adrenocortical adenoma versus carcinoma, we use the Weiss criteria, and greater than or equal to 3 of these criteria correlates with malignant behavior. You cannot use this criteria for oncocytic adrenocortical neoplasms or pediatric adrenal tumors. Features only seen in metastasizing tumors are greater than or equal to 6 mites per 50 high power fields, atypical mites, or invasion of venous structures. You can also use the modified Weiss criteria as well, where a total score of 3 or greater correlates with malignant behavior. Reticulin algorithm, you can use that to help determine if it's an adenoma or carcinoma, where in a carcinoma, it'll have a disrupted framework. Borderline cases are likely best categorized as having uncertain malignant potential. Oncocytic adrenocortical neoplasms, you'll have abundant granular eosinophilic cytoplasm. Many times greater than 90% of the tumor has to be oncocytic. You will use the Lynn-Weiss-Biskiglia criteria. Myelolipoma, benign, you'll have mature fat and bone marrow elements. Ectopic adrenal tissues, don't mistake for invasion or metastasis. You can have schwannomas, adenomatoid tumors, and sex cord stromal tumors. Adrenal medulla and extraadrenal paraganglia tumors. Pheochromocytoma, this arises from chromaffin cells in the adrenal medulla. All are malignant, but only 10% metastasize. It can make catecholamines. Classically, we'll have this nested Zellballen architecture with amphiphilic purple cytoplasm and rich vascularity. It'll be diffuse positivity for chromogranin, and sustentacular cells will be positive for S100 and SOX10. It's negative for cytokeratins, SF1, inhibin, melon A, and calretinin. At least 30% are familial due to germline mutations. Genetic testing is thus recommended for all patients. Paragangliomas arises from extraadrenal paraganglia, but morphologically and functionally like pheochromocytomas. You can have head and neck paragangliomas and sympathetic paragangliomas. Neuroblastic tumors, you have neuroblastoma, which is the most primitive and malignant, ganglioneuroblastoma, which is malignant, and you'll have neuroblastoma with Schwannian stroma, and ganglioneuroma, which is most mature and it's benign, and you'll have no neuroblastoma or neuropil. Neuroblastoma is the third most common pediatric tumor, where around 90% occur before age 5. And MYC-N is a major oncogenic driver. Amplification leads to higher risk. Composite Pheochromocytoma paraganglioma. Each component stains looks like it would usually. And related tumor syndromes include MEN1, think your 3 Ps, parathyroid hyperplasia, pituitary adenoma, pancreatic duodenal neuroendocrine tumors. MEN2A, think 2 Ps and 1 M, parathyroid hyperplasia, pheochromocytoma, medullary thyroid carcinoma. MEN2B, think 1 P, 3 Ms, medullary thyroid carcinoma, mucosal neuromas, marfanoid features, and pheochromocytomas. And familial Paraganglioma-Pheochromocytoma syndromes, caused by mutations in genes encoding subunits of succinate dehydrogenase, SDH. The most common tumor is Paraganglioma-Pheochromocytoma. You can have other specific tumors include SDH-deficient gastrointestinal stromal tumors, SDH-deficient renal cell carcinoma, carny triad, Carney-Stratakis syndrome. Well, thank you so much for watching, and we'll catch you on the next episode of Pathagonia. And as always, thank you to Dr. Shabrick for his excellent notes.